I know, it's fantastic.
It's my pleasure to introduce the chair of the next session, Dr. Michael Gannon, and his session is named Waste Not, Want Not, Ethics, Stewardship and Patient Care. Dr. Gannon is President of AMA WA, Head of the Department of Obstetrics and Gynaecology at the St John of God Hospital, Subiaco, and he is Chairman of the AMA Ethics and Medico-Legal Committee. Michael.
Thank you. When it comes to managing healthcare resources, doctors must balance their primary ethical obligation to care for the individual patient with their secondary obligation to use healthcare resources wisely. So some of you might remember your medical training talking about resource allocation as a core ethical principle. It's largely rolled into justice these days. At times these obligations may conflict, but focusing on stewardship allows doctors to find an equitable and realistic balance between the needs of the individual patient in front of you and the need for the wider community to have affordable healthcare in the future. The essence of stewardship is avoiding waste. It is not denying care because of scarce resources, otherwise known as rationing. The purpose of this policy discussion session is to assist doctors to become better stewards of our healthcare resources through learning how to identify the medico-legal challenges in effective stewardship, communicating with patients about resource use, especially where resources are limited, and how to participate in initiatives that identify and discourage ineffective care at both the institutional level as well as in the wider community. We will also be using the information derived from this session to help develop an AMA policy on ethics and stewardship to assist in our wider advocacy. The session will comprise 3 speakers and then we'll have time for a question and answer session at the end. Our first speaker today is Dr. Ian Scott. Dr. Scott is the Director of the Department of Internal Medicine and Clinical Epidemiology at Princess Alexandra Hospital in Brisbane. He's an Associate Professor of Medicine at the University of Queensland and Adjunct Associate Professor of Medicine at Monash University. He practices as a Consultant General Physician. Dr. Scott will outline 10 clinician-led strategies for maximising value in Australian healthcare. Please make him welcome.
Thanks very much, Michael, and it's a pleasure to be here. And I thank the AMA for inviting me to talk to this very important topic. I think that, as previous speakers have mentioned, we've got an increasing expenditure on healthcare. It's now approaching about 11-12% of GDP. And I think when you look at the graph, the things that stand out is that the state governments are absorbing more of that financial load, as we've heard, and there's a real worry that it's going to become almost unbearable for state governments to do what we're currently doing. But also, I think importantly on this graph is the increasing proportion of out-of-pocket costs that now patients themselves are incurring. And this has real implications in terms of making sure that patients actually get and receive and take and accept the interventions that we think are most effective for them in relation to quality of life and survival. We know that the percentage of GDP that state governments are taking on is increasing and the federal proportion is decreasing. But I think irrespective of whether we want to do cost shifting and blame federal or state, the overriding concern is what we can do to actually conserve resources and try to reduce waste in our system. And there is waste and efficiency in healthcare. This is from the Institute of Medicine in America, and yes, it is the Yanks, and they perhaps do things a little differently, and I think that they certainly probably have overutilisation of healthcare. But nevertheless, it's a first analysis to try to actually break down where is some of the waste in the healthcare system in the US, and we don't really have a comparable study in Australia. And yet perhaps we need to consider doing it so we can have a better idea of what proportion may be related to inefficiencies, what proportion is related to ineffective care, what proportion is related to gaming, fraud, etc. And these things unfortunately do occur. There is a concern that we're getting less for more. In other words, we spend more resources on healthcare. There's no doubt in the last half century we've had some terrific advances. And in relation to outcome benefit for patients in terms of quality of life and survival, we've made big advances. But I think there's a concern that we may be now reaching the top of the curve, and in fact we may even be going down the other side in terms of technology that doesn't necessarily confer benefit for patients, real benefit that's important to them. There's also a concern that there may be declining productivity. The Productivity Commission has looked at the productivity of the healthcare workforce over the last decade or so. This is a graph actually again from the US, but it makes the point that when you look at sectors that have contracted over time, and as you know we've been in a fairly constrained financial environment in the last decade, particularly following the GFC, that retail and manufacturing and other sectors of the economy have retracted, and even though this is US data, the same thing has occurred in Australia. Where the growth has been is in the healthcare sector, where our healthcare workforce has virtually doubled in the last decade. But yet the productivity from that workforce has been put into question in the reviews that have been done. Admittedly, the methodology is not clear, but the impression is that for all that extra workforce, are we actually getting a return for benefit in terms of patient care? There's also inequitable sector growth. If you look at the sectors, both within healthcare and outside healthcare, the biggest growth sector is hospitals, the sort of place that I work in. We've had reductions in welfare and as I mentioned, other sectors of the economy, including education, for example, which some would say is just as much a public good as healthcare. Therefore, I think it behoves us, certainly those of us who work in hospitals, but also in primary care as well, okay, for all that extra growth, are we conferring again a benefit that's proportionate to the amount of investment that's occurring? We know that there are some problems in relation to the quality of the healthcare that's given. We've had presentations earlier this morning about practice variation, how there's a considerable difference between different geographic areas, okay, in the amount of surgery or the amount of certain procedures that doesn't seem to be explained by differences in patients or the clinical characteristics of patients. So why is that? We also know that there's significant cost variation, as Dana Watson has pointed out. And again, this really can't be justified by differences in patients or the differences in types of operations or procedures that have been carried out. So all this suggests that there is potential here. There is potential waste in the system. What is the best care? Obviously is the burning question. And it could very well be that those who spend more may actually produce a better outcome. And I think if there's one thing that we're missing so far in all the data that we've heard is the outcome data. We hear process data, efficiency data, cost data, length of stay data, throughput data, What we don't have is, okay, what's the outcome data in terms of value for patients? The hospital that does spend more on a certain procedure may actually be producing a better patient outcome, fewer infections, fewer complications, better quality of life and function, more productivity for the patient to go back to work earlier. These things need to be factored in when we're looking at the cost equation. So the key driver of increasing healthcare costs, a number of things have been proposed, such as ageing population, more chronic and complex disease, population growth, cost inflation, falling Australian dollar now, rising salaries of the workforce. But in fact, probably the biggest single factor that's driving our healthcare expenditure is the growth on healthcare technologies, what we actually do, the equipment that we buy, the things that we do, the drugs that we dispense. That's what's driving most of our healthcare expenditure. And I think what we need is a reorientation in this whole debate, and that is, as I've mentioned, we've had a lot of focus on inputs in terms of resources, efficiency, and outputs in terms of activity, numbers of admissions, operations, procedures, clinic visits, etc. But I think we need to go the next step, and that is look at effectiveness in terms of outcomes, patient or community impacts in relation to quality of life, deaths, events. This is a value concept, and I think that's missing from our debate in healthcare at the moment. What I'd like to take you now through is 10 what I think are clinician-driven strategies by which we can perhaps reduce waste in our system. And this is something we all have to do at the coalface. It's not just the responsibility of governments or bodies such as the AMA, it's what we can do actually as individuals. The first thing is to minimise diagnostic error. I think diagnosis is a bit of a lost art in medicine, but yet clearly if you make a wrong diagnosis, everything that you do subsequently is for naught, is a form of waste. So we need to try to minimise delayed, missed or incorrect diagnosis, and they occur about 10 to 20% of cases. So it's not insignificant, and it's of interest that despite our increasing use of diagnostic technology, it hasn't necessarily reduced. Some of this is driven by system factors, but a lot of it is cognitive error, reasoning error on the part of individual clinicians, perhaps even groups of clinicians. So what can we do to try to reduce this? Well, I think we certainly need more training in our specialties in relation to diagnosis, making sure that is there a feedback loop that tells us if we got it right? Do our emergency physicians know whether they had their provisional diagnosis correct? Do we feed it back at the end of the hospital discharge, for example? If we have a referral from a GP to a specialist, does the GP get told perhaps that this may have been incorrect diagnosis? So we need decision support, we need perhaps a seeking of second opinions within our colleagues, and we need more analysis of diagnostic error. Perhaps more CPD points for those professional activities that actually monitor and minimise diagnostic error, and improved clinical reasoning. And I think electronic health records and decision support can aid this process, right, but it's not the be-all and end-all. And I think sometimes a lot is placed on electronic health records and decision supports as being the panacea, and that will actually reduce this sort of error totally, but it won't. I think the other dimension, though, is overdiagnosis, and this is perhaps more of a concern. That is where we do make a diagnosis, and yes, the condition does exist, but the condition wouldn't have made any impact on the patient's longevity or quality of life. They're incidentalomas. They're things that we've now picked up because our technology is so much more sensitive than it was perhaps 2 or 3 decades ago. There's a real potential for harm and waste here because we can label people as having conditions that really, again, aren't going to affect them. And it's significant. These are rates of overdiagnosis of asthma, hypertension, lung cancer, chronic kidney disease, gestational diabetes that Ryan Moynihan and David Henry and others have documented and studied. And as you can see, they're not 5 or 10%. They're in the 20s and 30s, perhaps even higher. So this is a significant problem now that I think we have to address. So how do we do that? Well, I think we need more funded research into the clinical utility of diagnostic and screening tests. We actually need to know that these tests not only diagnose something, but what then happens downstream in terms of what patients then get done to them and what their outcomes are in relation to whether they've survived or whether they have a complication from a treatment that we've given on the basis of a diagnostic test that discloses a condition that would have had no effect on them if they hadn't known about it originally. I think we need more rigorous assessment and reassessment of benefits of diagnostic and screening items on the MBS. I think it's somewhat appalling the number of items that exist on the MBS, particularly in relation to diagnosis and screening, that really haven't been subjected to proper cost effectiveness or outcome analysis. We should insist on validation of any new disease definition. So in other words, if we diagnose a new disease or extend an existing spectrum of diagnosis, then again, we really should know the natural history of that. So, for example, if we lower the threshold for gestational diabetes, what is the outcome? If patients weren't treated for that new threshold of gestational diabetes, what would actually happen in relation to fetal outcomes? Are they important fetal outcomes? And the benefit-harm trade-offs involved in intervening versus not intervening in someone who has a mild or new form or early risk factor but doesn't actually have overt disease. The second strategy is to discontinue low or no value interventions. It's of interest that in modern times, when people have done clinical studies, rigorous clinical studies, looking at so-called established practice standards, things that we take for granted that we've assumed was a practice standard, up to 50% of those trials actually look at that practice standard, find that in fact that original assumption is not validated. In other words, what we thought was an effective treatment is in fact no longer so. Unfortunately, these practices tend to persist, sometimes by vested interest, but often by our own professional intuition, our deep-seated conviction that these things actually do work. And there's a bias there. And sometimes it's even a legalistic bias in the sense that if I don't do this, I may be sued later if I miss or don't do something that the patients come to expect. We now have, fortunately, more than 60 specialty colleges in the US, the Choosing Wisely campaign, that have identified 300 high-volume scenarios where specific interventions are of little or no value. We have a similar campaign now in Australia, and Lynn Wicks is going to talk to that shortly. We know that there's more than 150 high-volume MBS items that have been studied now in some detail and of potentially low value. That's only 3% of all the items that are currently listed on the MBS, so we have a fairly big task yet in front of us. Here's just a list of some of those items, and I won't go through them by one, but these are not uncommon procedures. These are done every day in general practice, in hospital emergency departments, okay, but yet they're of little or no value, and we therefore really should stop doing them. So how can we go about this? Well, we need to develop, I think, some appropriateness criteria around some of these items, and there are methods by which we can do that. I think the RAND methodology in particular does work, and gives us an idea of rating an intervention in a particular scenario as 1 totally inappropriate to 7 appropriate according to individual patient circumstances. Perhaps we need to re-evaluate the MBS items and delist or reduce rebates for low-value care items, and that's currently underway now with the comprehensive management framework. The MBS is being looked at, but the progress has been slow, and I think there is still some political resistance to further that work. We do need to, I think, reorientate our MBS. There are items that clearly should not be at the rate they are. We need to now turn this concept of value into action and restructure the MBS. Perhaps we should have some ineffectiveness alerts that may come out of the Chief Health Officer. For example, when an intervention has been shown to be no longer effective, we certainly have safety alerts for devices that need to be recalled, drugs that now need to become off the market, but we don't have anything similar in relation to noting that a procedure that may not necessarily be an immediate safety or harm problem, though is ineffective, and therefore we should stop doing it. We need to have some audits of potential over-servicing, again in relation to those things that we know are ineffective. So, for example, if a hospital is doing arthroscopies for uncomplicated osteoarthritis, we should then have a closer look and see what were the indications for doing that in that hospital. Profile adverse events and resource waste arising from the use of lower value interventions. It's a double whammy for patients to undergo a procedure that they really didn't need, but then also to have a complication or adverse event that results from that unnecessary procedure. The third strategy is to defer use of unproven interventions. Medicos, like most humans, are very keen to take on something that looks promising, that gives us an advance. The public are assailed every day on the media of the next latest breakthrough from research institutes. But many of these things have truly been tested in the light of day. So we need to defer their use, not eliminate them or not give them any support, but simply not adopt them widely. And there's some examples that I've listed there where already we have a widespread adoption of some of these techniques amongst hospitals and general practice, okay, but in fact, they're still yet to be proven. There's also indication creep, where proof of benefit in selected patient populations then justifies people then saying, well, perhaps this will be good in other populations without the evidence to say that that in fact is correct. And that's certainly my concern as a general physician, where lots of older patients get treatments that have never been studied in that particular population. So we really don't know its safety or efficacy. So how can we defer use of unproven interventions? I think, again, we need more stringent and streamlined health technology assessment and cost-effectiveness analyses, and that can be done, I think, through a single agency rather than the multiple agencies we have at the moment, so we need to do better on this. Conditional listings for public subsidy for these new interventions, targeted to specific populations, restricted to selected sites, time-limited, and with good proper process and outcome, patient outcome evaluation before then they're put onto the MBS. And mandated prospective cohorts or registries, so that if something new is being used, then we have a registry that collects all the necessary variables to allow us to be quite certain with this intervention is of benefit. The fourth strategy is to select care options according to a comparative cost effectiveness. We can sometimes achieve the same benefit, even better, but with less. And I'll give you some examples there in relation to, from, I guess, a bit of hospital-centric practice, I must admit, but I'm sure there's examples in primary care as well, where the outcome benefits, again, in randomised controlled trials, are just as good with perhaps a shorter course of treatment, a less intensive treatment regime, right? A more simple procedure versus a more complex procedure, okay, where, again, we can save money and yet achieve a similar or even better patient benefit. So how can we then promote this strategy? Well, I think we require clinical protocols and guidelines to consider comparative and cost effectiveness. A lot of our guidelines that are produced by specialty societies really don't include issues around cost effectiveness. I think all societies, especially societies, need to assume responsibility for looking at cost as well as outcome. We need moderate high-cost committees, I think, in all hospitals. Mandate high-cost committees in all hospitals in relation to procedures, drugs, treatments and procedures, and to feed back that to the people at the coalface in relation to what has been consumed in a hospital or a general practice or a primary healthcare network and what's been achieved in terms of outcome benefit. The fifth strategy is to target clinical interventions to those who derive greatest net benefit. There's a bit of a risk treatment paradox where the people who are at lowest risk in relation to an adverse outcome often get the most intense treatment, whereas those who are at highest risk get undertreated. And that's been well documented. Interestingly, on the other hand, patients tend to go the other way. Patients overestimate benefits and they underestimate the harms. And some very useful work by Tammy Hoffman and Christelle Marr did a systematic review and found that in 2/3 of instances, patients overestimated benefit, underestimated harm. So we need to educate our patients not to expect something where perhaps the harm outweighs the benefit. There's also inequities in access to care in relation to race, ethnicity and social economic status, and this applies equally to preventive as well as therapeutic interventions. So what can we do? Well, I think we need to promote better use of prediction scores that actually estimate absolute disease risk. And I think the Cardiovascular Disease Alliance has done now very good work in trying to get general practitioners in particular looking at the absolute cardiovascular risk of patients before they start a statin or a blood pressure medication. So it's not just on one variable, it's on their total risk. We need to provide point-of-care decision aids that give us these sort of estimates of absolute risk reduction, and they are coming and they've been shown to be effective in improving clinical decision-making in relation to a number of scenarios where the benefit-risk trade-offs can be fairly close. The sixth is to adopt a more conservative approach nearing the end of life. We spend a lot of our healthcare budget on the last 12 months of life, and this is not to say this shouldn't be done. But what we need to do, I think, is recognise that, again, in many cases, that intervention, that expenditure, right, doesn't actually improve patients' longevity or indeed may even not improve their quality of life. We need to, I think, also be aware that there's a lot of inappropriate prescribing, particularly in older populations, and I have a particular interest in trying to reduce that in older patients, and we've shown that about 20% of medications, regular administered medications in older patients, are potentially inappropriate. So we need a more conservative palliative approach that prolongs survival, improves symptoms, avoids invasive care and lowers costs. You can actually get a triple whammy here. It can benefit all outcomes, all measures. And that's been shown in a large randomised controlled trial as well as a number of observational studies. So a palliative approach is not denying care, it's actually providing good care at lower cost with better outcomes for patients. That's a win-win situation. Advanced care planning, systematically applied to patients with advanced chronic diseases, also can yield similar outcomes, and we should have more of that in patients who we know have a life expectancy of 12 months or less. We need to plan ahead and to see what we can do to ensure that their remaining time is quality time for them, not heroic intervention that we think may just extend their life by 1 or 2 months. Improve clinician ability to more accurately prognosticate in such cases, and improving access to palliative and hospice care and advice. And as you know, there's decision assist folders on your desk, which I think is, again, a very useful way of trying to spread that sort of knowledge. And disinvest from interventions that don't improve survival beyond 6 months or substantially improve quality of life. A lot of money is spent, and even at the cabinet level, decisions are made to reimburse drugs which really have a very limited effect on quality of life or outcome. The seventh is to actively involve patients in shared decision-making and self-management. Again, studies have shown that patients who actively participate, fully informed, of the risks and benefits, tend to choose a somewhat more conservative approach. They'll be less likely to undergo an intervention. And that obviously comes back to us because we are obliged to give them those risks and benefits in a candid way, in a way that they understand and that actually has been shown to reduce unnecessary intervention. I'll just quickly move on, if the slides could move a little faster. Good. So how can we do this? Well, I need to promote a patient charter, but I think we need to emphasise there are dual responsibilities. Patients are obliged, I think, to disclose relevant information and to commit, after discussion, to the agreed management plan. We need more public education campaigns around shared decision-making and self-management, and again, these websites and other resources now are increasingly available. Reorientate specific MBS items towards shared decision-making. So, for example, the 75-plus health assessments and extended primary care items for GPs. Those sorts of items could be used to look at advanced care planning, shared decision-making, de-prescribing, and to see whether any intended treatments and procedures coming up are, again, of maximal benefit. More professional training in this, and in relation to advanced care planning in particular, to try to harmonise the different legislation around those documents. The eighth is to look at operational waste and mismanagement. This is the dross, the everyday daily grind where things get repeated, tests get duplicated, which again incurs costs. We would estimate that about 20 to 25% of investigations are probably unnecessary on the basis that they've already been done before or they're not indicated. There's drug formularies of expensive patented medicines, costly implanted devices, highly skilled, highly paid clinicians performing tasks but perhaps lower paid, lower order clinicians could do just as well, and potentially preventable errors and oversights. We know that about 12 to 16% of total hospital costs are attributed to conditions that patients actually acquire in hospital. So how do we go about this? Well, perhaps more efficient system performance, certainly quality and safety governance in institutions such as my hospital now take centre stage. Quality is now an issue. Value-based purchasing frameworks rather than perhaps activity-based funding. Guideline concordant care, which hopefully decision aids can again help with. And indication-based tests and procedures and drugs. More rigorous program management and procurement. To me, it's deplorable how much money we actually lose in our procurement processes for public hospitals and contracts that aren't done and looked at closely. These are big dollars. And programs that are instituted, capital investments that are made that then subsequently are shown to be not the best return on investment. Lower prices for generic drugs and devices, restructuring of the workforce and awards, and more emphasis on audits, benchmarking and feedback, which we've seen examples of today. Strategy number 9 is to accelerate creation and diffusion of effective care delivery innovations. This is now getting into the macro level, but we all need to be involved in this process. Traditional clinical research methods such as randomised controlled trials, of which I'm a lover, often too slow and expensive in solving many of the everyday care delivery problems. Yes, we need them for drugs evaluation, for procedure and operations, specific things that we're doing to patients. But in relation to the complex process of actually care delivery, service configuration, randomised controlled trials won't cut it. So we need more action and operational research involving a number of methodologies which I've listed there. And there are some examples of some of the things that people have done in recent times using those sorts of methodologies that have actually given us very important insights into what works and what doesn't. I'd like to see that every hospital and health service and primary health network actually has a clinical effectiveness review body. In other words, so we can get the data that Diane Watson was talking about, look at it in terms of what's actually happening at the local level, look at what resources are being used, but importantly also what outcomes are being achieved in relation to patients. and with that, then decide, okay, what can we do in terms of targeted quality and safety improvement projects and programs to actually improve that care, using the data that's available in so many other different sites that have already been mentioned, that at the moment sit there in Canberra or other places but never really get used and don't get back to the coalface. Perhaps we need a national clearinghouse for service delivery innovations that have been field tested and worthy of wider adoption. So there's some of the things that I think we can do. There's some big necessary reforms around the MBS schedule, looking at DRG funding in relation to the value concept, bundled and blended care payments as well for populations, looking more at hospital substitution and avoidance programs, telehealth, integrated primary care, multidisciplinary patient-centred medical homes, etc. These have been shown to be a benefit, but they require restructuring of what we do. Here's my annual savings tally board. What I've tried to do here is bring together a number of analyses that people have looked at in different ways in relation to what we can do for cost. Per year, if these estimates are correct, and I grant you, they're estimates, they're not necessarily fact, but we could save $22 billion, or 16% of all health expenditure in 1 year if we adopted these sorts of approaches. That's versus $3.5 billion over 5 years saved from the doomed co-payment proposals in 13-14. This I think is important stuff. We can actually save a considerable amount of money if we just provide better care and we don't have to worry about co-payments and all the rest of it. Medicare will not be saved by these things. Piecemeal incentives, we need major structural reform. More measures and monitoring. Yes, I think we have enough measures and monitoring, we don't need yet more. We need perhaps better outcome measures, but in process measures I would argue, no. Do we need more standards? I think we have standards. We need to make sure that the standards that are already there are adhered to and we meet them. More accountability processes, I'm not so sure. Internal markets don't work. Just simply saying that the technology we have is going to be better isn't necessarily the way out. Precision medicine is given a lot of focus, but I'm not convinced yet that has a real role to play. Electronic health records will help, but it won't be the be and end all. And recurrent restructuring your health department certainly won't help us. So, in closing, I think these are two, important documents that are worth reading that have just come out in the last month. One from the Productivity Commission and one from the College of GPs. We need reform, and I hope that the AMA can lead this agenda. Thanks very much.
Thank you, Dr. Scott. Our second speaker is Dr. Sarah Bird. Dr. Bird's the Manager of Medico-Legal and Advisory Services at MDA National. Dr. Bird will provide a medico-legal perspective on stewardship in relation to the practice of defensive medicine, providing a practical outline of the threshold for medical negligence and the management of medical negligence claims. Please make her welcome.
Thank you, Michael. Thank you for the opportunity to participate in this conference, and I'm greatly honoured to be invited to be involved in this session. My task over the next 20 minutes is to talk about defensive medicine, and to particularly talk about defensive medicine in the context of doctors as stewards of healthcare and using our resources wisely. Now, I must admit this has turned out to be a difficult task. The concept of defensive medicine is quite slippery, and its impact and trying to understand its impact on healthcare resourcing is not obvious, and as a result it can be hard to try and work out, well, what are the solutions and how do we deal with it? So I decided the best way of tackling the topic was to really look at it from a claims manager's perspective. And I have to tell you that you need to remember that my perspective on medicine as a claims manager is kind of that tip of the iceberg perspective on medicine. So essentially I see day in and day out things that have not gone well in medical practice. So looking at it from that perspective, I wanted to have a look at 5 questions and see where we get to with that. So what is defensive medicine? It's important we're all understanding and talking about the same thing. How prevalent is the concept of defensive medicine? Is it actually the major cause? Ian Scott's talked to us a little bit about the no and low value tests and interventions in medicine. Is defensive medicine the cause of those? Does it actually reduce, if you practice defensively, is it actually going to reduce your risk of being sued? And then finally, how can we reduce the frequency of defensive medicine? So, we need to have the same definition. I've chosen, there are a myriad of definitions of defensive medicine, some of which actually include things that are positive for patients, such as increased communication and so forth. But for the purpose of this presentation, I've chosen the definition of the ordering of tests and treatments and procedures, primarily to protect the doctor from liability, and rather than substantially furthering the patient's diagnosis or treatment. So the definition I've chosen is really a deviation from sound medical practice, which has been induced by a fear of liability. So it's not talking about things which have a positive benefit. So at best it's going to be using up resources which could be used elsewhere, and at worst it's actually going to cause harm to patients. So how prevalent is defensive medicine? It's actually quite difficult to get a handle on this, and a lot of the studies are of variable quality. And what you're trying to work out when you're surveying doctors about defensive medicine is they've taken an action, and what would their action have been in that situation if they'd had a different belief system about their risk of liability in those circumstances. So it's not an easy thing to measure. I think it's true to say that the concept of defensive medicine originally came from the US, as a lot of things do, and so I thought I'd start with a US study that was actually done by David Studdert, who's a Melbourne-based legal researcher and academic, and this study is quite widely quoted when people are talking about defensive medicine. So David Studdart's group had a look at a group of US specialists that were a high risk of litigation. So that was the emergency department physicians, he looked at radiologists, he looked at obstetricians and gynecologists, general surgeons, neurosurgeons and orthopaedic surgeons. The study was done in 2004, and it was done in Pennsylvania, which at the time was going through a litigation crisis, and a lot of the insurers were actually leaving the state and leaving the doctors bare. And so not surprisingly in that situation, 96% of the doctors that were surveyed in that study reported that they were practising defensively. So they were ordering tests and performing diagnostic procedures and referring patients based on their fear of liability rather than weighing up the benefits and risks of the patients in front of them. So that's the US. I mean, we're different to that. So let's have a look at a country which has got a negligent system which is not dissimilar to ours in Australia. So this is a UK hospital-based doctors who were surveyed back in 2008 through to 2011. And again, you see a lower percentage, but still a reasonable number of doctors in response to that survey that were reporting that they do practice defensive medicine. There's very little data in Australia, and the only study that I could find was one that was conducted back in 2007, which again looked at Australian doctors both in the community and hospital-based, and it found that 55% of them ordered more tests, they thought, based on a defensive medicine basis. I think the interesting thing is that when they were looking at this survey, they divided into doctors who'd experienced a medico-legal problem and those that had not experienced a medico-legal problem. And perhaps not surprisingly, those doctors who had been involved in a medico-legal matter were much more likely to practice in a defensive manner. And it reminds me of a case I was involved in quite a number of years ago, which involved a young female GP who had a very ill-founded claim against her by a patient alleging a delay or failure in diagnosing hypothyroidism. The claim was easily dispatched because there was very little merit to it. But about 3 years later, I was contacted again by the same GP who reported that she'd come to the attention of Medicare at that point in time. And she was in fact the highest order of thyroid function tests in Australia. And it seemed to me that every patient who came through her door was getting some thyroid function tests. I must say the medical advisor from Medicare was very sympathetic and the matter was put to an end. And hopefully over time that sort of pendulum swung back to normal after that experience. So defensive medicine is here. And then one of the things that there we go, that I had a look at was our Choosing Wisely campaign, which was introduced, which Lynn Weeks, the next speaker, is going to talk about in some detail. But I had a look when that was publicised in Australian Doctor, the magazine that goes to all Australian general practitioners. It was quite interesting to see, just amongst a lot of the online comments, you could pick out the comments with doctors expressing their fear. And Lynn, this is going to be one of the barriers that you're going to experience in terms of trying to introduce Choosing Wisely to the doctors. I really like the last comment that was made there, which I think is sort of a bit of wishful thinking and lateral thinking, that perhaps those that are writing the rules or choosing wisely could end up being the defendant in the case that they're involved in. So it is something that doctors are expressing and talking about. Before I move on to the sort of negligence framework, I do want to sort of tackle the issue, which I think is really important. I mean, is this concept of defensive medicine that it gets talked about, is it actually the major cause of doctors ordering the no or low value test that Ian was talking about in his presentation? I think the answer to that is no. It's certainly not the sole cause, and I don't know whether it's even the major cause. There are a whole range of reasons why we as doctors and the community, so our patients that we serve, have this belief or this bias towards more rather than less healthcare. And one of the main ones is this concept of anticipated regret. Nobody wants to be the doctor in the emergency department who sends home the young woman who's had a bit of chest pain and palpitations, who then dies of a pulmonary embolus the next day. So there's this concept of not wanting to miss anything because the outcome and the regret that would be associated with that outcome is very hard to bear. So diagnostic uncertainty is less able to be tolerated. Ian's already touched upon that issue of commission bias. Our patients inevitably overestimate the benefits and tend to underestimate the harms of tests, and will often come in requesting. There's a lot of stuff in the media now about health and will come in requesting tests. I think there are some issues with our fee-for-service care for some of the low-value procedures, but one of the biggest problems is also the lack of time. I think the time that's required to discuss with patients the benefits and the risks and the reasons why a particular test or procedure is recommended or not recommended is very time-consuming, and sometimes it's probably easier just to order the test rather than have the discussion. And then finally, there's that issue of the fragmentation and lack of continuity of care. So there's that concern that you're not going to see the patient again, and so in which case you better order everything now. Or worst case, when the patient then goes to hospital, they have exactly the same tests repeated. So let's get to our question. Does defensive medicine actually reduce your risk of being sued? So I put on this slide here the definition that's included. You'd all be aware that in the early 2000s in Australia we had a raft of tort law reform that was introduced that has in essence made it much harder for patients to bring claims against doctors and other professionals. So this is the definition from New South Wales. There are slight variations in the definitions across Australia, but they're all essentially similar. I love the way the law works. They kind of put it in the negative. So you're not negligent if you've acted in a manner that was widely accepted by peer medical opinion as competent medical practice. The other thing to mention is that we've also had some really important case law in Australia. So 10 years ago, there were a lot of claims that were based on, and we're talking about these failure to diagnose claims when we're talking about the use of tests in medicine. And there are about 50% of the claims against general practitioners, so they're a large proportion of the claims that we see against certainly non-procedural doctors. And in those claims, they would often be framed, if we go back prior to 2010, in the form of, well, there was a delay in diagnosis of my cancer, and as a result I've had a worse prognosis and outcome. And if I'd been diagnosed earlier, then I would have done better. I've lost the chance of a better outcome. And that loss of a chance could be anywhere down to 1%. You know, it could be this tiny, minuscule loss of a chance. Ultimately, a case went through to our High Court in 2010 which said, well, that's just ridiculous, you know. You're going to be successful in every claim if you can argue that loss of a chance in every case in those failure to diagnose claims. And so now the standard is it has to be proved on the balance of probability. So there must be an over 50% chance of having a better outcome before those claims can be brought. report. Now, that in itself has reduced substantially the number of these claims that we're actually seeing as a defence organisation. So, does defensive medicine reduce your risk of being sued? I've just chosen 3 cases that I want to try and highlight for you what I see as the significant issues in claims from a claims manager's perspective. So the first one I've chosen is based in the US, and this was actually an article that was published back in 2004 by Dr. Merenstein, who was a young family physician trainee at the time that he saw this 53-year-old patient who'd attended just for a general checkup. He had a wonderful discussion with the patient about the benefits and risks of having PSA testing, and as a result of that discussion, which was actually documented in the medical records, no PSA test was performed. The patient was later diagnosed with metastatic prostate cancer, and he successfully sued, interesting enough, not Dr. Merenstein, but actually the institution in which he worked, and was awarded $1 million. Dr. Merenstein wrote up that case in the Journal of the American Medical Association, and it gathered enormous sort of coverage and input from the profession. And he said it was quite heart-wrenching reading this description of being involved in this claim. And he said at the end, "I now order a lot more tests. I'm nervous around patients and I'm not the doctor that I should be." So how does that translate in Australia? I guess the first thing to say, well, we're quite different to the US. I've already flagged that at the beginning. And it's important to be aware that those publicised cases that we read about from time to time, they are not representative of the majority of claims. Nobody's going to run a matter to hearing involving their doctor unless you are very confident that you are going to win that claim. So the ones that you read about in the press, which are the only ones that you're aware of because they're less than 5% of the claims, and the vast majority of claims are resolved on confidential terms behind closed doors, and you are not aware of what's going on in those claims. So those publicised claims are not representative. And again, in this room, many of you will remember a case a couple of years ago which involved Mr. Almario and Dr. Varipatis, where essentially at first instance the GP was found negligent for not referring the patient for bariatric surgery. The patient in that case was morbidly obese, he had fatty liver, he ultimately went on to develop hepatocellular cancer, and he at first instance successfully sued his GP because he said, well, if the GP had referred me for bariatric surgery, I wouldn't have developed hepatocellular cancer down the line. Fortunately, that decision was appealed, and quite rightly and quite properly, the GP was successful in defending that claim. But as I say, those are not representative of the cases that we are managing. And to use the example of prostate cancer claims, which we do see from time to time, the commonest cause of those claims are where the doctor has practiced defensively. So it's a bit counterintuitive. You're more likely to get sued, I think, in these claims if you're practising defensively, and I'll explain to you why. So in most of those cases, the PSA test is ordered as part of a whole raft of screening tests. They're not tests that you're necessarily going to follow up quickly, might be as part of cholesterol and various other tests and so forth. The result comes in, and for one reason or another, and Ian has touched upon this in his presentation, probably I would say probably up to 20% of those failure to diagnose cases are the result of what are called system errors. So the result is there showing a markedly elevated, unexpected PSA result, and it's not acted upon by the GP. Those cases, as you would appreciate, are inevitably negligent. If you have the result in front of you, which suggests that further action's been taken, you can't then rely on the fact that the patient hasn't contacted you in that case. And so those matters are actually inevitably settled. The second case I wanted to look at to try and illustrate a truism in medical negligence claims is acute low back pain and imaging. And Lynn, I've chosen one of the Choosing Wisely recommendations from the College of Radiologists. And so this is don't perform imaging for patients with non-specific acute low back pain and no indicators of a serious cause for low back pain. And I read in the Choosing Wisely that low back pain is the third most common medical presentation in general practice. Now, how do I see that as a claims manager? Some of the most expensive claims that we see as a claims manager are these cases where there's a failure to diagnose. It's either cauda equina, discitis, epidural abscess. These are very high value matters because, as you would appreciate, the patient is left significantly disabled. In these cases, in my experience, it is invariably a difference in the recollection of the events between the patient and the doctor. So the patient says, I saw Dr. X, I told Dr. X that I had this terrible pain in my back, I'd been having fevers at night for weeks. I also mentioned that I'd recently had a dental abscess which had been treated, and doctor said, oh look, it's just some mechanical back pain, don't worry about it. From the doctor's point of view, they will say, I did go through the red flags, I asked about them, they were all negative, and as a result, I didn't order any imaging in that case. I would love to see as a claims manager, and I know we bleat on about medical records, I would love, and I have never seen one of these cases where that information is documented, those negative findings are documented in the medical records. And I think the reason I don't see them is because they never come to me as claims, because that would go to a plaintiff solicitor who'd say to their client, you don't have a claim, the doctor's done the right thing, they've asked about all of these things, you're not going to be successful once they've got their expert opinion on the case. So I can't highlight enough the importance of medical records. I wonder if it is the third most common, and the GPs in the audience will be able to tell me why there isn't a checklist that comes up in your medical records that you can essentially just go through and note that you've followed through and checked for any of the red flags. So the third case I wanted to touch upon, again to illustrate something that arises in claims, and this is the issue of DVT and ultrasound. I'm picking on the College of Radiologists one. So this was one of their recommendations, not to order duplex compression ultrasound for suspected lower limb DVT in ambulatory patients unless the Wells score is greater than 2, or if it's less than 2, a D-dimer assay is positive. Now, somewhat ironically, in the same week, just a few days, Lynn, before all of these guidelines came out, there was a coronial case in South Australia. And I've just pulled out just a few quotes from the coroner's findings, but this again was quite widely publicised in the GP press. And here the coroner's expert has made some comment about the Wells score, and it's not particularly useful. And the coroner has then made this recommendation to the College of GPs, well, you need to tell your GPs, do not place undue reliance on this Wells score. Now, I don't know that coronial matter. All I've done is read the findings, and it may well be that the expert opinion got lost in translation, such that the coroner's made that recommendation. But I guess it highlights the importance of having good expert medical opinion in all of these cases, because ultimately, if you look at that definition of negligence, it is a peer opinion standard that we're looking at. So remember that in nearly every state and territory in Australia, to actually commence a claim against a doctor, there has to be a critical medical expert report in order to actually commence proceedings against the doctor. Sadly, we still see occasions of what you would call hired guns in terms of expert opinion, and so it's something that we really need to make sure that we're making sure that the information that goes to court is of high quality. And so just to finish, my last question is, well, how can we reduce the frequency of defensive medicine? I guess this is a good segue for you, Lynn. Evidence-based practice, those guidelines are held in very high regard when things are considered by courts and other bodies. And if we allow those low-value tests to continue to be practiced, somewhat counterintuitively, that then becomes the standard of care that we all have to overcome. You will find experts that say, oh yes, I would have done this in this particular case. And so it's absolutely essential that we look at and follow those evidence-based guidelines that are available. I've touched upon the importance of medical expert opinion in cases. Ultimately, that is the test upon which all of your conduct will be considered. And I hope I've highlighted just in a small way that defensive medicine, in fact, does have its risks associated with it. So, of course, from a professional point of view and from a medical defence organisation point of view, we hope that you will be able to practice high-quality medical care, meeting your duty of care to your patients, and that not worrying about those medico-legal risks, and then not falling into that trap of practising defensively. So thank you for that.
We're having trouble with the web for the Q&A, so we'll have microphones for questions after our third speaker. Our third speaker is Dr. Lynn Weeks. Dr. Weeks was originally a hospital pharmacist who was awarded a PhD for her study on quality use of medicines. In 2013, she was made a member of the Order of Australia. Dr Weeks is the CEO of NPS Medicine Wise, which is facilitating the Choosing Wisely Australia campaign. Dr Weeks' presentation will focus on the campaign and how doctors can start a conversation with their patients on the appropriate use of resources. Please make her welcome.
Conversations are very powerful things. They change your point of view, they let you put your point of view, and they often connect you with an idea or a person that maybe you wouldn't otherwise have been connected with, so that your decision making improves. And so I hope that the conversation that the AMA is starting as part of this policy development for stewardship and appropriate use of resources can really, start the conversation with the profession to take us to a really strong place. We have launched Choosing Wisely Australia just in April this year, kickstarting what we've called a national conversation about more appropriate healthcare. And we had medical colleges and societies coming on board for that to take a lead on identifying those tests, treatments and procedures that they thought were of either proven low value, therefore wasteful, or in fact harmful. So 5 colleges and societies came on board initially, and I'm going to read them out because otherwise I won't get them exactly right. The Royal College of Pathologists of Australasia, the Australasian College of Emergency Medicine, the Australasian Society of Clinical Immunology and Allergy, the Royal Australian College of General Practitioners, and the Royal Australian and New Zealand College of Radiologists. So this was quite a courageous group in that they had seen Choosing Wisely in the US, and they were prepared to say, we're going to have a go at this in Australia. They didn't really know what they were getting into, but they have come with great energy and a lot of leadership to this whole enterprise. So that's been, I guess, a really wonderful thing to see. So I'm just trying to make this work. Yeah. So Choosing Wisely Australia, as I said, is built on that US experience where there are now 50 or 60 colleges and societies that generate lists of things that are considered to be of low value. The goal is to enhance quality care and to reduce inappropriate or unnecessary care. So to reduce waste, to reduce harm, and to increase appropriateness. It's led by clinicians, and this has been really, really important. I think the clinicians leading the conversation is one of the strongest and most important parts of Choosing Wisely. But patient care is at the centre because obviously that's what you do every day. It's evidence-based, it must be evidence-based, and that's the thing that's probably been challenged most in the program. How good is the evidence? Where is the evidence? What sort of evidence is it? And there's a premise that good communication is central to quality healthcare. I guess as Ian and Sarah have both said, good communication takes time, and that maybe is one of the reasons that tests and other things find their way into more frequently into care than perhaps they should. These are recommendations, they're not guidelines. They're recommendations about things that you don't need to do as often as you do. Very few of them are black and white saying never do this. So they're not things that you would say, okay, that needs to come off the MBFS schedule entirely, but it might need some more nuance around it. And the language is quite intentional, therefore, is things to question, not things not to do. This movement, as it's now being called internationally, is now being rolled out in Canada and the Netherlands, Denmark, Germany and England. And one of my staff who's running this, who would have been here otherwise today, Robin Lidner, who's been spearheading this at NPS, is in the UK this week for a round table where people are sharing their experience internationally to see what's happening. So why are we involved in this at NPS? I hope most of you know NPS Medicine Wise. We are an independent, not-for-profit organisation. We've been running now for about 17 years, so we have a fair experience in the health sector, particularly around medicines, but more recently also in the area of medical tests. Our task, as we see it, is to empower people, whether that be clinicians or consumers, to make their best decisions about medicines and medical test use. And from that, we believe we'll get better health and economic outcomes. When we measure those economic outcomes, we measure both things like hospitalisations avoided, but also changes to MBS and PBS, and that's because our biggest customer is the government and they'd like to see those bottom line changes as well. But we do it in a quality environment, so we're always looking to measure the health outcomes at the same time, because I think if you're not doing that, you're obviously going to run foul of good quality practice. We do have a lot of programs, particularly in primary care, and we're trying to think about how we might make those more relevant to those people working in specialty practice, and I guess choosing wisely might be a good conversation for us to start having with specialists. Our role in this whole choosing wisely space is very much a facilitation and coordination role. We cannot make the lists, we cannot lead the debate. This is really something that the colleges and the societies must do, because they're the people who really know this and who have the credibility, but also the relevance to make this work. We do help with the communication strategy, because that's one of the things that we are quite skilled at. And so in terms of raising awareness, bringing stakeholders together, stakeholder engagement, mobilising key opinion leaders on some occasions, and then working with the media, whether that be social media, traditional media, on the website. And that's, I guess, a strong thing that we can bring. We think also that we can help with implementation, and this is something to be tested yet, because we're really at the very beginning of Choosing Wisely Australia. We have 5 lists of 5 things, and the colleges and those 5 colleges and societies are now working with us to say, well, how will we implement this? And the first thing they will do is go to their scientific meeting and present these lists back to their members and talk about what they can do with them. So we really are at the beginning. But one of the things that we do is we run therapeutic programs at MPS Medicine Wise, and we know quite a lot of the recommendations that have already been made fit very well into those programs. And so whether it's long-term use of proton pump inhibitors or treatment for high blood pressure without doing a full cardiovascular risk, then we know those things will fit well into our programs. And the other thing we feel we can bring, because we now have, as I said, 17 years of background of doing evaluation in the health sector, and we evaluate all of our programs economically, health outcomes wise, and then also in terms of process and things like REACH. So in the US, the biggest criticism of the program was that it wasn't evaluated very well. And what happened? How much changed? Where did it change? And I think that's what we can bring in Australia, because we do have people who are interested in looking at that data and want to know those answers. So how does it work? So the colleges develop a list of 5 things to question. They identify tests, treatments and procedures that they think are of proven low value or carry unnecessary risk. So among the lists, and I'm not going to show them all to you, you'll be pleased to know, but among the lists that the things that were recommended to question were food allergy testing, prostate cancer screening, vitamin D screening, routine self-monitoring of blood glucose for type 2 diabetes without insulin, benzodiazepine prescribing for people particularly who have a history of previous misuse of substances, including alcohol, many emergency medicine procedures, and ankle and spine imaging, as you've heard. So some of these things are almost no-brainers, that you would expect them to be on the list, but still we find there are high rates of use of many of these things. This is the list from the Royal Australian College of General Practitioners. The College of General Practitioners had a really interesting process for coming to their list. They asked their members to provide input, and they had a lot of members, so over 100 responses, I understand, to that request for what sorts of things should be on this list. I don't know if that's a lot, but it sounded like a lot to me coming back from busy general practitioners. They then, a group, the quality committee, ranked those down, or shortlisted those down to 10, and then they went out to their members and surveyed them and said, what of these 10 are the 5 most important? So that's how they got to their list. So it is very much a consultative process. And what they identified was long-term proton pump inhibitors where there was no attempt to either reduce the dose or take someone off treatment if they were otherwise uncomplicated. Not commencing treatment for hypertension or high cholesterol without doing a full cardiovascular assessment or cardiovascular risk assessment. As I said, not advocating routine self-monitoring for blood glucose. That recommendation is interesting, and it's probably the only one that we had criticised. And the criticism came from those people worried that the nuance wouldn't be understood, that this was people who were not on insulin. It was people who weren't, and it was the idea of it being routine for all patients. So that was really the only one that we have so far have found to be contentious. Not screening asymptomatic, low-risk people with for various cardiovascular tests, and also they're not prescribing benzodiazepines. So that's was their first 5. They have 5 sitting in the wings. Obviously, they're a short list of 10. So we're expecting, I guess, another list from the College of GPs quite soon. The other thing that we do as part of this, and I think this is an important part of the conversation, this is the consumer element of it. And we've started this in a small way with 5 questions we encourage consumers to ask their doctor or discuss with their doctor when a test is being ordered. I think this is a pretty big ask, quite honestly. I think consumers find it really difficult to have this conversation, and I think we need to find ways to help them have the conversation. But the sort of questions are, do I need the test? What will it tell me? What will it tell you? How are you going to use the information? I think they're important questions that should be addressed. As I said, this is the beginning. The colleges and societies are now working with us to say what are the consumer resources that would help the doctor and consumer have a conversation that's really meaningful around particular tests. Because really, it's often consumer demand that's driving some of these tests. And I think in some cases, and if we look at the back pain example, there's probably more consumer demand in that than there is maybe in some of the more technical ones. The other one that the Society of Allergy and Immunology mentioned was, in terms of allergy testing, quite a strong consumer drive for that as well. So we do need to facilitate these conversations and do more than just have a few questions. We do need to develop some more resources. We're very much at the early stages of raising awareness, conversations in the media, website and social blog sort of conversations. What we need to move to is those shared decision resources, and that will really need to be led by clinicians who understand how they want to have those conversations in practice, but also, I guess, by consumers being part of that, because we need to bring them on the journey. Consumers Health Forum have been very involved in this whole process and very supportive, so they're bringing their expertise and their networks to the party as well. And collaboration, as I said, is absolutely critical. So for us, we've been very fortunate to have an advisory group who have led the strategic development, implementation and eventually evaluation of this whole process. That's chaired by Associate Professor Richard King, who has been a great advocate for the whole process. He's currently speaking with chairs of various colleges, convincing them that they really want to be part of the next wave of this. And the committee has really brought together a wide range of expertise to help us at MPS understand the relevant, how we make this relevant in the context of clinical practice. We do have agreed criteria for how the lists are formed, and the criteria are that the test, treatment or procedure must be frequently used or reasonably frequently used. We don't want something that's just never used and there's no point in even talking about it. It can be unnecessary, or it may be that it causes harm, so it can be about waste or harm. There are often simpler, safer or other alternatives, so again, there needs to be something that people can do that's a better alternative, and it must be evidence-based. And the final thing is it must be within your own scope of practice, so it's not about pointing the finger at somebody else's craft group, who can certainly do better, but it's at looking within your own craft group. And I think there's probably still a little bit of criticism around the pathology and radiology ones because they're about referrals, but I think for those guys that's what they're seeing, so it's irrelevant. It is relevant. They make the recommendations that they've made. We've also had 2 representative panel groups who have guided the list formation and shared information as the lists have been formed. And that's been very important because we've found that there's been common elements find their way onto lists from different societies and craft groups. So that, I guess, reinforces the message and reinforces the idea that these really are things that are of low value. This is our 5 colleges having their red carpet moment at the launch, proudly holding their 5 lists. The things that they said at that time, so it was a very energised launch, more than I've seen in a long time, I have to say. And what they talked about was how to how it allowed them to engage their members. Their members really bought into this conversation and were really, I guess, pleased to be contributing to the idea about how health resources can be allocated or reallocated in a positive way. The colleges talking with each other and sharing information was something they also valued, and it allowed the colleges also to raise their profile, and they found that useful as well. So I think for us, we probably underestimated that element of this whole process, and the fact that we said it is about conversations and it's happening across the profession as well as between doctors and their patients. So I'm not going to go a lot into why we need this, because I think Ian has probably done that better than I could possibly do. But as I said, not all tests will add value. The clinical experts leading the debate and this conversation about budget allocation for me is very important, because there'll be lots of conversations happening in different places, as you're aware, over the next little while. So having very much a clinical lead to this, I think, is helpful. It must be evidence-based. Consumers need to be part of this conversation, or we'll still have that issue of consumers driving a lot of demand. And we know that there is that pressure that Sarah was talking about, to think about all clinical possibilities. So if we can identify what's not a good idea, then, or what is at least worth questioning, I think that helps us in that process. And it does perhaps eventually drive greater accountability. I'm not so sure about that one, but we do know that guidelines tell us what to do. They very rarely tell us what not to do. So if we put the two together, perhaps we have a better system. So the critical success factors that we have found here is that, as I said, that it is health profession-led. It establishes the credibility, the trustworthiness, it makes it relevant. The development and the ownership of the list sits with the colleges. So they are the standard holders. They are the people who are doing the training. So I think it's really appropriate that it should sit there. It's at arm's length from payers and government. We've had to work quite hard at this. We've had very enthusiastic approaches from health funds and from government, and the colleges and societies have been very clear that they need to be at arm's length. This process can play out. By all means, those people might use the lists in some ways, but we need to be very careful they're not used in the wrong way. Consumers are part of the conversation, and the language is very important. We're not, I think as someone said earlier, talking about rationing here. We're talking about quality care, reducing risk and reducing waste. And we would see this as one message with many voices. So the next steps are that we're now about to start on wave 2, moving to some additional colleges, bringing some additional colleges on board. The Royal Australian and New Zealand College of Ophthalmologists, College of Nursing, College of Intensive Care Medicine, and the Society of Intensive Care Medicine. So that's good to see. If others would like to become involved, we're very happy to have more conversations with other colleges and societies. I think it's important, though, if we can then link that into the policy paper from the AMA, that gives a whole nother layer to the professional conversation here, and that's something I'd like to see as well. Thank you very much.
All right, we've got time for questions now. Just while people are making their way towards microphones, just one that got registered on the computer before it fell apart, from Jeff Loy. Diagnostic error may be considered a failure in part of subset of clinical expertise. At a superordinate level of skill, perhaps more research is needed into the nature of and how to improve clinical expertise. Is it worthwhile considering research into development, improvement and maintenance of clinical expertise, acknowledging this may need to be discipline and or specialty based?
Yes, well, I think, as I said, I'm not so sure that in many of the colleges and societies that there's enough emphasis on the art of diagnosis. We spend time on history taking and examination, but I think, just from my own experience when I actually examine candidates for the College of Physicians, it's often a problem of synthesis and actually understanding what the patient is really all about. Differential diagnoses are thrown up, and it's often said to be a kudos that if a physician candidate can generate 10 different diagnoses in the differential, that's a good outcome. Well, it's not. I argue with them, you have to be parsimonious. What are you going to commit to? What do you think is the provisional diagnosis? And let's talk about that, and you give me the reasons why, the pros and cons against that provisional diagnosis. And that's where I think sometimes we fail. There's a lot of emphasis amongst candidates too about diagnostic testing. So not only do they mention their 10 differentials, and they'll give you a list of 20 investigations they then might like to do to rule this in or rule that out. And for me, they get demerit points because, again, that to me is bad practice. It's not a test of knowledge or how much I can do, it's what you should do in relation to the diagnosis you think is most likely and how that test is going to be most useful in ruling something in or out. So we do need, I think, more training in this regard. And I think in relation to, people have said, well, is it just simply a matter of increasing expertise in a particular area? No, I think it's not. I think that our demographics is changing. We have increasing numbers of patients with multiple conditions, multiple presentations, different manifestations of different diseases. So we have to become all experts at trying to get more certainty around what we think the diagnosis is in that sort of situation.
Gino Pecoraro.
Interesting. One of the things that we've seen at one of the hospitals I work at is to try to force people to think through these things, but unfortunately all that's evolved is that we have what we affectionately call the wall of shame, where there's a wall of pieces of paper with a series of tick boxes that our poor registrars for almost every condition that the people who organise the tick boxes could think of, there's a form that they've got to go through that guides them through the process. While everybody accepts that this is very important, is there anything that anyone on the panel can suggest to stop us going forwards with more walls of shame in other hospitals?
Yes, I think that what we need is more thinking doctors. We don't need more checklists. We don't need more, diagnostic aids that list a whole range of different things that then could be sort of looked at or considered. I don't have an answer for you in the sense that I think we just have to practice. We have to practice clinical scenarios and simulations where people are presented with everyday but complex and uncertain situations and help them reason those through. And as I said, I don't believe that necessarily that computerised decision support when it comes to diagnosis is necessarily the be-all and end-all. In fact, I think it'll take us backwards, in fact.
Mark Kangura.
Thank you. I'm a diagnostic clinical radiologist, and I'm frustrated in receiving a request form, not order, and I will come back to that in a minute, where the information given is totally incomplete, and there are a huge number of findings on an examination study which are irrelevant, but if you're not given any information, what do? So you generate additional tests because somebody's actually forgot to mention, very significant clinical information. And that, I think that communication there, just providing that one bit of information, sometimes just saying leg pain, there are two legs. There are 5 findings which apply to both, and just knowing that it's the left leg actually changes your view and your differential and what you think you should do. We've talked about communication. Language is very powerful. When you use the word order, you're assuming that the person at the other end is subservient. As a clinician, diagnostician, I abhor the term order. Please request, consult, don't order and insult. Thank you.
I'll take that as a comment.
Fair point.
Did you want to answer that or not?
No, I mean, in our hospital, our radiologists are empowered to say, you haven't given me complete information, I'm not going to do this, I'm going to ring the person up and I'm going to speak to them and try to get a much better idea of why they want this test and what they're hoping to get out of it. So I guess in our environment we can control things a little better, perhaps out there in general practice and private radiology practice, I'm not so sure how it works perhaps as well as that, but that's what we need more of, more communication. I couldn't agree more.
Paul Neeskens.
Yeah, Paul Neeskens, GP with a soft interest in epidemiology. Ian, you're right on the money. Go for it. We've got to go down this line. I think there has to be something else we have to be planning for. Even if we had all the best prevention, did all the screening, never got overdiagnosed, never smoked, had a BMI of 22, and did everything perfect, in 2030 there will still be more evidence-based effective interventions that we can't afford. So we are going to have to be ready for the low value, medium value, low cost, high value, or low value, medium value, high value interventions. And somewhere along the way, someone's going to have to make decisions about who can get what. even despite everything else being perfect and no waste, etc. That funnel of profit books is very illuminating. We've got to be scared about that. The solution to that will be ethical. Someone's got to make those ethical decisions, I believe, about value. And that has to be us doctors, not the hospital administrators. So what I want is that how can we be prepared for the public, the policymakers and the practitioners to be ready for the framework, to be making those decisions. So in your 10 strategies, I was wondering whether there should be an 11th, is to be getting ready for a national database that's readily understandable of cost effectiveness, whether that's dollar quality data or some repository where we as clinicians or policymakers and the public can say, well, we are not going to do Gardasil vaccination because it costs $500,000 to prevent one case of cancer of the cervix, but we will do cataract surgery because it only costs $1,000 to purchase a quality year of life. So what do we think about a strategy whereby we have to prepare the Australian public about dollar for value in terms of medical interventions? I'll let you think about this for a minute because I want to ask Sarah a quick question. And should we have a national database? Is that maintained by the NHMRC or by Di Watson's group with the NIPA? But it should be up there. My question for Sarah is a quick one. In the course of time, will we be getting sued for over-diagnosing?
That's a great question, and all I can say to you at the moment is no, that's not what you're being sued for in general terms, but it's going to potentially be on the horizon, yes.
So Ian, what database?
Well, yes. I think the concept you're talking about is number needed to treat. So how many people do we have to treat to produce one outcome, whether it be a saving of death from some communicable disease or whatever, and then marry that with, what's the cost of the numbers needed to treat? So if you treat 1,000 people to prevent that one event, how much cost do you incur? So that work is, we have these estimates around. It's just that, as you said, no one's actually brought it together into one sort of central repository. And I would argue that the NHMRC would be the logical place to have that repository. I think the NHMRC is keen on producing fact sheets which actually, allow people to see, in these sort of common high-volume scenarios, the risk benefits, and then the costs. And we need that cost element added to the fact sheet, which at the moment perhaps is lacking. So it's an expansion of my strategy 4, where we need more comparative cost effectiveness data, which brings those concepts in, and I think the NHMRC perhaps should lead that work. But coming back to your point though, it still must be informed by clinicians, and researchers who are aware of the nuances of clinical practice, because there's always limitations to these fact sheets. There are going to be exceptions, that's true, but it certainly, I agree, would give us a guide in terms of prioritisation as to what we should be spending money on, and things that we perhaps unfortunately can't spend the money on because there is an ever-increasing demand, that's true. But what I've noticed really over the literature, really, if you look at the clinical advances that we've made, while we've made some big ones, even in recent times, the actual incremental benefits from new technologies get smaller and smaller. So we've made the big gains in the last half century. We're still making some gains, but they're getting smaller, but more costly. So yes, we're going to have to deal with this problem. But we're not alone in this. It's a problem around the Western world if you travel around and speak to people.
Yeah, but I think the important thing is the public has to be ready for this discussion. Sure. Not just the administrators and doctors with their secret numbers, but the public.
Xavier, you?
Yes, thank you to the panel for your excellent presentation, and particularly thank you to Dr. Bird, who you actually presented to AMA Victoria at a junior doctor ethics workshop a couple of years ago, so thank you again for that. My comment first is regarding my colleague Professor Kanga as a radiology trainee. The answer in public hospital is to actually just whip up the medical record online so we can actually access the old patient record, and that means I don't even have to read the request form because usually it's illiterate because I can't read the handwriting. That's the first comment. But my question is actually about communication. You're talking about how clinicians request forms and provide clinical information. In terms of reporting things like urgency, like for example an urgent finding, how do you find the radiologist should communicate those findings in the report? Should they be in the body of the report? Because we have no recourse to enter notes into a patient's clinical record from our perspective. It's only in the report that we can do that. How do we as radiologists and pathologists, for example, how do we actually document communication?
I mean, I think that's a really important issue, and you'd be surprised at the number of cases we see which do come down to the formatting of the reports, be it pathology or radiology. In fact, I had a case last week where the first paragraph included the fact there was metastatic disease. It was a CT of the back, actually, and it wasn't included in the rest of the report, which went through level by level, and there was no conclusion. And the GP in that case completely missed the first paragraph, and then it was rather disastrous because went off to the chiropractor with low, mechanical low back pain, and that's my claims manager perspective on life. So I think there are some really important issues in terms of the way reports are formatted and highlighting results. There have been other coronial cases that you've probably seen where there's been criticism of both pathologists and radiologists for not phoning the requesting doctor. So it's that communication and trying to judge how critical is that result that I need to make it get through. So it's both the communication and also the communication in the written report and having it. I don't understand why there's not a standard format perhaps for some of those things.
We try.
Maybe just add to that, in GP software it might be displayed in different ways as well. So even though you may present it out one way, it may come back in looking another. So.
Yep.
Okay, there's 5 people standing. If you make your questions brief, we'll get through all 5 of you.
Wally Jamal, I'm a GP and a Senior Medical Advisor for Avant. Sarah, just a quick comment. I agree with everything you've said. Thank you. Just a comment on the, or question on the MBS funding. I know that you mentioned, removal of items that have absolutely no value. Problem is, as someone who, although I'm not speaking on behalf of the department, or someone who sits on 2 subcommittees looking at these low value items and reviewing the MBS, it's very, very difficult. And it's difficult because we have little evidence for a lot of what we do. And little evidence doesn't necessarily mean no evidence. And unless we have evidence of severe harm, it's very hard to get something removed. And secondly, the reason that you can't apply the cost-effective analysis framework and economic modelling on something that you have little evidence for. And so we're stuck. And really what I think it should be is actually aligning the MBS with good quality practice, which is what this whole program is about. So how do you remove items for something that we have little evidence for? Question.
I absolutely agree with you. I think removing the items is going to be really difficult in this MBS review. There might be some wording around some of them that give some indication about how they might be used. I think what's probably, for me, more useful to think about is the fact that we do have an Atlas of Variation from the Safety and Quality Commission now that will give us some data to show differences in practice. We'll have Choosing Wisely giving some indication from the colleges and societies about what they think is good practice. Maybe if we can triangulate all that together, we'll get to a better place. I don't think the MBS review by itself will achieve that.
John Bunting.
John Bunting, plastic and hand surgeon, but now purely medico-legal. And my question to Dr. Bird, whose presentation I greatly enjoyed, relates also to cost effectiveness and thinking of, and also to absence of risk of the intervention, thinking of the common practice of somebody coming into an emergency department with a knock on the wrist and having a plain X-ray. Now, perhaps there's some defensive medicine like that perhaps it is reasonable to tolerate.
I mean, yeah, I accept that, and I think listening to some of the discussion about the cost benefit, it's very difficult as a clinician looking at a patient who wants a test and to then have that discussion about cost benefit.
Doesn't be a lot of trouble if the person did have a fracture.
Yes, correct.
Hi, my name is Alan. I'm a surgical SRMO working in Western Sydney. I'm just wondering if someone might be able to comment on the effect of the 4-hour rule, the NEAT target, NEST target implementation on the rates of overdiagnosis specifically, as well as the frequency of shotgun-style diagnostic ordering.
Yes, thank you. That's a very good question. Perhaps I can talk to that because I'm at PA Hospital, and I think as one of our earlier speakers commented for the Minister, our hospital was able to get our NEAT target up from 33% to about 60%, and I was part of a group that did a fair bit of the work involved in that. And we were concerned about that. We really were. We thought, okay, are we going to have people being rushed through ED, tests being ordered just to sort of make sure that everything's sort of covered so they can leave ED more quickly? We haven't seen that. We've looked at the cost data around that, and if anything, we've actually seen a somewhat a bit of a reduction, actually, in the cost of ED investigations. And why? Because part of the NEAT project was that we got general physicians and specialists to integrate more with ED. In other words, we were being asked to see patients in ED more earlier in their trajectory and before perhaps certain things were ordered that didn't need to be ordered. Right? So we were assisting, I think, our emergency colleagues to be a little more selective in what they did, right? And to give them some confidence, okay, that yes, we think this is the diagnosis, and no, you don't need to do that CT head scan or whatever it might be. So I think it's how you go about it. I think if you don't have an integration with ED and they're just pushing people through, I think you run that risk. But I think if you can use it as an educational opportunity, as we did, and I think it's produced a benefit.
Gerard Siegel.
Thank you, Gerald Siegel. I'm a GP in a group practice. I've been in practice for 40 years. Bleeding strokes. When I first started in practice, there was 2 to 3 strokes per week in my practice. Now, we don't hardly see any, but we treat hypertension. Bleeding peptic ulcers, about 1 a week, and often there were people who died. Haven't seen one for ages. But NSAIDs and OTCs are encouraged like crazy. People buy them. It's on TV to buy them. Opioids for pain. We were told we were under-prescribing, under-treating pain. Now we're being told we're doing too much. So what the heck is being encouraged? What are we supposed to do? Are we going to put our heads in the sand? I'd be really interested to come back to this presentation in 20 years. Choose wisely, I say. I'd be interested in your comments.
Yeah, I think they're good comments, because it is about targeting and tailoring for individual patients, which is what you do every day. And it's about asking the question, not about saying this is black and white. It's not saying use PPIs less for those people who need them. It's saying for those people who can be scaled down a dose, scale them down. And I think that's something that clinically you can make the best judgments on.
Stuart Salfinger.
I'm a gynae oncologist from Perth. We've spoken a lot about the sort of high volume but lower cost things and ways to reduce costs there. My question is there a role for regulation of some of the high cost things? And in particular here, I'm thinking about something like robotic surgery, which is growing exponentially in the country at the moment.
Yeah, I mean, I think that comes back to I think health technology assessment needs to be a little more stringent than it currently is and a little more coordinated. I sit on the Queensland equivalent or branch of the Health Technology Assessment Policy Committee, and we have these discussions, and we have had discussions in relation to Queensland public hospitals as to whether we fund robotic surgery, CyberKnife, Gamma Knife, lots of other high-cost technologies that are concentrated in tertiary centres. I'm not convinced that we actually have the process right. I think also there has been an inclination of some tertiary centres on reputation basis to be seen as having the first of this new promising technology, and they push it. And I think we do need to be more circumspect in how we actually use and evaluate this technology. It comes back to my suggestion that we need to have good prospective registries in these sites of excellence of these new technologies. So before we spread them out or adopt them in other hospitals, there perhaps supposed to be 1 or 2 sites that actually has the technology, and they have it for, say, 2 to 3 years, and they examine what patients come through, what outcomes are achieved, what the selection criteria is, what the learning curves are, etc., etc. Unfortunately, I think this technology tends to be rolled out too quickly before it's been properly evaluated, and I would argue perhaps more in the private sector than in the public sector. And we need to, I think, curtail that.
I'd like just to finish the session by inviting up one special guest. We're very fortunate to be joined today by Baroness Elora Finlay of Llandaff. Baroness Finlay is a Professor of Palliative Medicine at Cardiff University. She's a past President of the Royal Society of Medicine, and of course, as many of you know and may have met her, she's the President of the British Medical Association. Perhaps to touch on her expertise in an area which has been a key endeavour of the Ethics and Medico-Legal Committee, end-of-life care, euthanasia, but perhaps even her insights on the issues we've discussed today. I think we would love to take the opportunity to hear from her, so please make welcome Baroness Finlay.
Thank you so much. It's been an absolutely fascinating session, and the principle of justice, the question between the just allocation of resources and the right of the patient to have the best treatment within the resources available, has been a really illuminating session, and I congratulate you all on it. In Wales, we have prudent healthcare, which has grown out of choosing wisely, and we're moving on with that. And I'm glad to see you've got the nurses involved, because actually a lot of nursing is very protocol-driven and can be very wasteful of resources. And however much the doctors are doing, you still need to get that shift in nurse thinking. In the Ethics Committee in the BMA, we've been extremely active. We're one of the most active of all in the BMA. And we also have a Science Committee which produces expert reports as well. So we have that professional activity. One of the things, amongst many, is the Science Committee has been looking at the problem of chronic pain and pain in palliative care. That's been important to me because I'm in palliative medicine. And the Ethics Committee is doing an investigation into end-of-life care and issues around perceptions of physician-assisted dying, which incorporates physician-assisted suicide and euthanasia. On the palliative care front, I personally have a palliative care bill which will get its first reading in the House of Lords on Monday. I won't actually be back for it in time. I've had to get somebody else to do it for me. But that is to try to make sure that specialist palliative care is available everywhere across England. We've achieved 7-day services across Wales, where I'm the clinical lead, but England has black holes in its provision. Just a quick word about the physician-assisted dying debate, which seems to be driven by a small but very vocal minority of people who are frightened about what lies ahead of them. We've looked at this. The BMA has a position of being opposed to physician-assisted dying, to physician involvement. My own personal view, and I must say this is my personal view, is that if society decides to go down that road, you don't have to have doctors involved. This is not for medicine. This is a single lethal dose of drugs. You don't need a prescription, you're not titrating dose or whatever, and it is much safer to have a court decide eligibility and have a court-appointed person who would then be involved. But medicine has enough to do trying to prevent suicide and trying to provide good care than to get involved. Lord Carlisle, who is a criminal barrister, and I have established a think tank called Living and Dying Well. And if any of you are interested in the subject, there are a lot of papers researching into all the evidence from around the world that are on that. It's a think tank. We do have a stand because we're not supporting physician-assisted suicide, but we've really tried to look and stand back and look at the evidence. Some of the problems in the UK, although the public at first sight appear to be asking for this, when you actually expose in depth what's involved, that drops back to about 43% pro and 43% against. So the headline about you wouldn't let a dog die like this disappears. Doctors, about 2/3 are opposed, but in palliative medicine it's much higher, it's 82% opposed, and only 4% are prepared to have an active involvement in any processes, which I think is important and actually heartening from my own group who are involved in dying patients all the time. Problems with the doctor being a gatekeeper. Well, we know from the pathologists that 1 in 20 diagnoses are wrong at post-mortem. We know we can't predict prognosis. You can toss a coin on a prognosis in between 1 month and 1 year. That's your level of accuracy. We know that assessing mental capacity is extremely difficult and fluctuant in people with severe medical illness, let alone medical and mental illness. And I think the hardest thing of all for us as doctors is detecting coercion from a family. As Baroness Cumberledge said, where there's a will, there's a family, and there's often money too. How true. We've looked at some data from Oregon, which is often held up as a paragon of virtue. Actually, pain relief before and after they changed their law did not improve. It actually got worse. It may be that the legislation was a distraction. Looking at the Netherlands, I do think there's a trend of normalisation and routinization, which one can't ignore. 1 in 25 of all deaths in the Netherlands and now from euthanasia mostly, but with a small amount of physician-assisted suicide. And that's deaths of all causes. That includes road accidents, everything. So it seems to be very high numbers. And in Belgium, it seems as if an awful lot are outside the law, quite apart from within their law. But the one that concerned me most of all, in some ways, is there's been no downward trend in violent suicides in any of those jurisdictions. So something else is going on there. That's just trying to give you a very quick summary of where we're at. We have a UK-wide investigation at the moment through the Ethics Committee of the BMA looking at these issues. It'll be interesting to see what emerges from that, from conversations. But I'd just like to finish by congratulating you all on an absolutely fascinating meeting here of the AMA, and really a most impressive session this morning. So thank you very much indeed. And I hope we'll be able to welcome many of you across to the UK and the rugby players. Cardiff has a wonderful Millennium Stadium. As you know, that's my home. So I look forward to seeing you there too. Thank you.
I'd like to thank Dr. Kate Stockhausen for all her hard work within the ethics section of the AMA and for putting together this very thought-provoking session. So thank you to Kate. And I'd like, on behalf of you, I'd like you all to join in thanking our speakers, Dr. Weeks, Dr. Scott and Dr. Bird.
Thanks, Michael. Can I convey the apologies of the AMA for the issues with the access to the electronic Q&A system? It's a venue issue. They've got some issues with their internet, and our people are doing our best to assist them with this. So that's an update on that. Now I would like to introduce to you Professor Liz Raymond from Decision Assist. Liz is the Director of Metro South Palliative Care Service and Director of the Brisbane South Palliative Care Collaborative. Her research interests include symptom management in palliative care patients and palliative care service development and delivery. Welcome, Liz.
Hello, everyone. Thanks for the opportunity to talk to you. I won't keep you from lunch for too long. This presentation is actually really just to familiarise you with the program known as Decision Assist. It's been funded by the Federal Department of Health, and in short, it's about increasing the capacity of primary healthcare providers to provide quality end-of-life care for aged Australians who want to be looked after in the community and also probably to die in the community. The importance of providing such care has got a lot of press coverage lately. It's recognised for some time by governments, policymakers, peak bodies such as the AMA, the RACP, RACGP, ANSPAM, lots of other healthcare advocates, and more recently this week by the Queensland Minister for Health, who released the Queensland statewide strategy for end-of-life care. My concern is what we're having is like a thermocline up the top with the advocates and the policy makers. We've got a lot of activity happening. Below that thermocline, we've got a lot of clinicians really trying to get this message of quality care across, but there just seems to be this barrier. And basically, if we don't get the funding, we can't do the work. So it really is a case of no money, no mission. The need for this quality end-of-life care was described fairly succinctly in the Grattan Institute in their Dying Well report, which stated, Australians are not dying as they would wish. Surveys consistently show that between 60 and 70% of Australians would prefer to die at home, but this is realised only by about 14%. That discrepancy represents a service gap that Decision Assist is actually trying to help to decrease. This is the website for Decision Assist. It's really a multifaceted program aimed at various professions working in the community. I really, in this presentation, only want to talk about what's being offered to GPs. And the reason that I'm focusing on the GP component, I used to be one, but I'm now a palliative care specialist, but it's really apparent to everyone that it's the GP role that's essential for achieving optimal patient and family outcomes in the community in palliative care, in aged care. So what we're trying to do is introduce to GPs a palliative care framework so that they can embed that in their routine practice to prompt proactive care for older patients. So really what this means is that everybody can be on the same page as a person's condition deteriorates, and you don't have to make decisions in emotionally charged situations with different family members. And the reason for the usefulness of such a framework now, I think, is because the demographics of death in Australia are dying, as is the acceptance of palliative care increasing. Historically, palliative care was seen as something attached to cancer. 40, 50 years ago, there weren't a lot of effective treatment, so people would go through treatment regimes, their disease would progress, the person would start to deteriorate very quickly, popped over to palliative care, and palliative care was about symptom management and managing the processes of dying. But with changes in disease-modifying treatments, probably across all neoplastic and non-neoplastic diseases, the trajectory towards death has become much more similar across all causes of death. And today, really, most deaths are expected. Because most deaths are expected, it allows for the possibility that they can be planned for. I just want to show you this slide. Many GPs say when you do all the surveys that they don't do much palliative care. But in fact, they tend to be looking after an ageing population and they will be looking after a high percentage of their patients have, say, less than a year to live. With the increases in both neoplastic and non-neoplastic treatments, the distinction between a curative intent of treatment and a palliative care intent of treatment is becoming really blurred. With that blurring, it becomes much more difficult to manage people. We used to see three classic graphs. Somebody with cancer would go along and then suddenly their condition would deteriorate. People for end organ failure, such as cardiac failure, their trajectory would go like this. People with frailty syndromes or dementia would go like this. But in fact, those three distinctions, I think, are disappearing more and more. And what we're left is with this sort of grey movement from curative to palliative. At the origin there, for any disease that's progressive and non-curable, which is most of our diagnoses, clearly your treatment is going to be much more curative, but as the person, as that disease progresses, you move more into the palliative. There's no fixed point or line anymore to change from curative to palliative intent. That movement from curative to palliative is going to be influenced by a whole range of patient factors as well as physician factors. The patient factors will include their physiological condition, their choices in life, their culture, their religion, spiritual beliefs, socio-demographic positions, and for the doctors, they'll also have different trigger factors for moving from one to another. Another problem for GPs for this greyness is lack of information from specialists. They often say we just don't get enough from the hospitals to know where people are at. And so that makes it harder for GPs to approach. Perhaps it's now time that we consider your quality of life rather than low-value interventions or treatments for you. So because of that greyness there, that hesitancy, it introduces hesitancy or a loss of confidence and indeed avoidance about when to embark on a palliative care approach. So the framework, the palliative approach framework of care, we are suggesting that that is one way for GPs to navigate that greyness without getting caught up in hesitancy. So I'm just going to, you probably can't read that very well. This is really just the palliative approach framework. This has been really built on work from the United Kingdom. There's been more work done in Australia, but it's pretty well, each of these components is pretty well evidence-based. And really it's based on 3 different prognostic columns. Yes, I know prognostication is an insensitive tool, and we have many prognostic clinical indicators, and none of them tend to work very well. But we are pretty good at saying, I think this person either has or has not another year or so to live. So this framework is based on 3 columns with different prognostic trajectories. The first one is the prognostic trajectory is likely to be greater than 6 to 12 months that this person has to live. The second one is if you think the person has less than 6 months to live. And the third one is for people who are in the terminal phase or where a diagnosis has been, a diagnosis of dying has been made. Because prognosis is insensitive, each of those columns are linked by scattered lines so that if you get the prognosis wrong, the person just moves into a different prognostic category. The purpose of this isn't to get the prognostication exactly right, it's to enable people to be mindful that this is probably the time to introduce a palliative care approach to their care. Each of these trajectories is associated with a key clinical process, and those processes are advanced care planning for people who have around about or more than a year to live. The second, if people have less than 6 months to live, the key clinical process there is about case conferencing. Now it's time to get everybody on the same page so that when the person starts deteriorating, you don't have what we call the sister from Kansas syndrome, where so many people are agreed about what the management plan is and somebody comes screaming over the hill and says, you're not doing that to my father. And then in the final trajectory there, the key clinical process is the use of an advanced care management plan. Those plans, the use of a terminal care management plan. Those plans are different depending on whether the person's in a residential aged care facility or whether they are in their own home. Oops. Sorry. So basically, how does that fit with the rest of the decision assist resources? Well, for each of those 3 key clinical processes on decision assist, we've got all sorts of educational and resources available to support people looking for advanced care planning or case conferencing or management in the end stage. So now I'll just go through what we've got for GPs. GPs are an incredibly difficult group to reach. There's 26,000 of the critters out there working in all different sort of service environments under different conditions. The reach is just so hard. So what we've tried to do here is get as many different ways of getting the word out as we can. So in terms of clinical support, the 2 major things are the Specialist Palliative Care Phone Advisory Service. That's a number, it's available 24 hours because we know that as people are dying, those unexpected symptoms can come up at any time. There is also an Advanced Care Plan Phone Advisory Service. That's 7 days a week, but it's only between 8 a.m. and 8 p.m. because in reality, advanced care planning should be done more proactively. And certainly not in the middle of the night. The other thing we have is a whole lot of accredited education for GPs. We have workshops that we run around that framework. For the first time in the CPD for RACGP, GPs need a clinical audit, so we've developed a clinical audit that allows GPs to compare their pre and post management of people at end stage after they've had an intervention of the workshop or indeed an online module. We've now got an RACGP, I think they released that yesterday. This is all pretty new. So they released that online module yesterday. And here's the picture of it. That's what it looks like. It's actually, I'm really impressed with it. I think it's technologically very good. That's also up on the ACRM website. The other thing that we've got for ACRM, this is a funny little clicker, isn't it? We've got a case of the month. That's an interactive thing that's facilitated by a specialist palliative care service provider, so we can just sort of have a virtual conversation about how to manage different patients. And then the next one is the PalliAged app. This is gorgeous. You can download this. Basically, it goes through how to care on for people who are suitable for that framework that we've that I've just pointed out to you. So it talks about assessing your older patients, going through advanced care planning, what happens when the person starts to deteriorate, what are the drugs you can use. Just as an example of some of the things that you get through that PalliAged app, you can just pop it onto your iPhone. This is a list of medications that has been endorsed by ANSPAM for use in terminal care in residential aged care facilities. We've been trying to encourage residential aged care facilities to set up impress systems. That's met with variable success, both within the facilities themselves and from the government. But anyway, that allows for a set of drugs that people can become familiar with, so they're more confident about using them in their practice. And also associated with that, that's available through the PalliAged app, this is a guide to the pharmacological management of terminal symptoms in residential aged care facilities, just to give an idea of when to treat, how to treat. If that's not working, what else do you try? And then the other thing is for advanced care planning. We know that this is incredibly important, and we know there's no MBS items for this. You can only get a long consult. But we suggest that perhaps this can be incorporated somehow in practice, either at the 75-year plus health check or the 55-year one for Indigenous peoples. But an interactive workshop based on advanced care planning skill that has been developed and also accredited through the RACGP, and that will be running out soon through the new primary health networks. So really, in summary, Decision Assist is the Department of Health initiative that supports the clinical management of older Australians living and dying in the community. And GPs really are pivotal to this, and so we're trying to encourage them to embed that sort of framework, a palliative approach framework of care, into their routine clinical practice, and such practice can be well supported by all of the resources offered in Decision Assist. Thanks for your time.
Well, thank you very much, Professor Raymond. That was a very interesting presentation. We're going to break for lunch and we'll be back here at 2, but I have 3 reminders. These policy sessions attract RACGP and ACRIM points. Please find the link in the session feedback form on the conference website, and the certificates of attendance are available after each session from the CPD booth. Second reminder, the urgency motions will be debated this afternoon at 4 p.m. Third reminder, could you please register for the soapbox sessions? Only one person wants to say anything tomorrow at the soapbox session so far. No, they still only get 3 minutes. So, okay, see you at 2 o'clock. Thank you.